Hi and welcome. This is episode 2 in our series on inflammation. In episode 1, we discussed what is inflammation, what are the cardinal signs of inflammation, the types, and vascular and cellular events occurring in acute type of inflammation. I hope you all watched that video. If you haven't done that, do that now. The link is now available on the screen and is also in the description. I suggest you watch that video first. Now, in our second episode, that is this episode, we will be discussing the mediators of inflammation and the general features of chronic type of inflammation. Okay, you all ready? Let's dive into the topic. Mediators or chemical mediators of inflammation are large and increasing number of endogenous chemical substances which mediate the process of acute inflammation. They are endogenously released chemical substances which act at various levels of vascular and cellular events, thereby mediating the process of acute inflammation. They are released in response to certain stimuli. They act on different targets. Usually, they have a very short lifespan, and sometimes they may even have harmful effects. They are usually grouped into two types: cell derived and plasma protein derived. Cell derived mediators can be preformed and stored, like histamine, which is stored in granules of mast cells, the main action of which is vasodilation and increased vascular permeability. And it is also one of the main culprits causing itching and pain in inflammatory conditions. Or these chemical mediators can be newly synthesized on demand, like prostaglandins, which is an arachidonic acid derivative. Arachidonic acid is a fatty acid, a normal constituent of phospholipid cell membrane. This arachidonic acid is released from cell membrane by phospholipases and then activated to arachidonic acid metabolites or eicosanoids by one of the two pathways, either cyclooxygenase pathway, the product of which is the one I mentioned, that is prostaglandin, or lipooxygenase pathway, the product of which includes leukotriene. So the cell derived mediators can be preformed or newly synthesized. The plasma derived mediators include the complement system, which is activated either by the classical pathway through antigen antibody complexes or alternate pathway via non-immunologic agents like bacterial toxins, cobra venoms, etc. Activation yields products like C3A, C4A, C5A, and these activate mast cells to release histamine. One another product, C3B, is an opsonin. What is opsonin? We discussed in our last video while discussing phagocytosis. The plasma derived mediators also include the products of coagulation cascade like fibrinopeptides and products of fibrinolytic system like plasmin, or the kinin system like bradykinin. The mediators of inflammation has scope for even more elaboration, but for the time being I will not digress into that and stick to the task in hand. Okay. So let's move on to the morphology of acute inflammation. There are a few varieties in morphology here, some of which are based on the type of exudate. For instance, we have the serous type where the exudate is watery. Example is pleural effusion. There is the fibrinous type where the fibrin content of the fluid exudate is high. Example in pneumococcal and rheumatic pericarditis. There is the serofibrinous type, which is a combination of both serous exudation with fibrinous debris, commonly referred to as bread and butter type. Example is rheumatic pericarditis. There is the catarrhal variety where there is outpouring of mucinous material. Example is our well-known common cold. Then there is the purulent or suppurative type where there is accumulation of purulent material or pus. Example abscess. There is the hemorrhagic type where there is vascular damage like in acute hemorrhagic pneumonia in influenza. Apart from these varieties based on exudate, there is also the membranous type where there is deposition of true membranous structure as in membranous bronchitis. There is the pseudomembranous type where there is deposition of fibrinous membrane-like material. Here, plasma exudes on the surface and coagulates. This one, together with necrosed epithelium, forms a false membrane, and this is called pseudomembranous type. And then there is ulcer, which is defined as local defect on surface epithelium. That's it for the morphology of acute inflammation. Coming to the fate of acute inflammation, it can take one of the three routes. Number one, there can be complete resolution, a complete return to normal. Number two, there can be healing by scarring. This happens when the tissue destruction is extensive and then healing occurs by fibrosis. And then there is number three, the chronic inflammation, the condition where acute inflammation progresses to form a chronic inflammation. And that brings us to our next section, that is chronic inflammation. Chronic inflammation is defined as a prolonged process of inflammation in which there is tissue destruction, massive tissue destruction, and parallel healing. Chronic inflammation is of prolonged duration with more tissue destruction and parallel healing process. This chronic inflammation can occur by one of these three ways. One, it can be a sequelae to acute inflammation. As we saw earlier, the acute inflammation can either resolve or heal by fibrosis or scarring, or it can progress to form a chronic inflammation. That is what we saw in fate of acute inflammation. So, a chronic inflammation can occur as a sequelae to acute inflammation. Recurrent attacks of acute inflammation. This can also progress into chronic inflammation. And number three, chronic inflammation can start de novo. That is, there can be chronic inflammation starting afresh, chronic inflammation from the beginning. This happens when there is infection with organism of low pathogenicity. Remember, organism of low pathogenicity, not higher pathogenicity. The organism of lower pathogenicity is the one which causes chronic inflammation starting de novo. Coming to the general features of chronic inflammation, the distinguishing feature of chronic inflammation is mononuclear cell infiltration. There is infiltration by mononuclear phagocytes or macrophages, lymphoid cells, epithelioid cells, etc. And the other feature is, as we saw in the definition, there is tissue destruction and healing progressing parallelly. There is tissue destruction which is brought about by activated macrophages which release a variety of biologically active substances like protease. And there is parallel healing or proliferative changes resulting in the formation of inflammatory granulation tissue. Coming to the types, there are two: chronic non-specific and chronic granulomatous. Chronic non-specific refers to chronic inflammatory reaction with formation of granulation tissue and healing, all the features we just now discussed, but which is non-specific. On the other hand, chronic granulomatous inflammation is one in which there is characteristic histologic tissue response by formation of granulomas. The classic example is tuberculosis. Now is the time to discuss in a little bit more detail the general features of chronic granulomatous inflammation. Chronic granulomatous inflammation is the one in which there is a distinct histologic pattern characterized by presence of epithelioid cells. Epithelioid cells are nothing but modified macrophages. So chronic granulomatous inflammation is one in which there is a distinct histologic pattern characterized by presence of epithelioid cells which are modified macrophages. Now this lesion called granuloma is defined as circumscribed tiny lesion about 1 millimeter in diameter, composed predominantly of collection of modified macrophages called epithelioid cells and rimmed at the periphery by lymphoid cells. So what is granuloma? Granuloma is defined as a circumscribed tiny lesion about 1 millimeter in diameter, composed predominantly of collection of modified macrophages called epithelioid cells and rimmed at the periphery by lymphoid cells. Coming to the pathogenesis of granuloma, in simple terms, granuloma is a type 4 hypersensitivity reaction. Hypersensitivity reactions we will deal in a separate video. For the time being, just remember granuloma is a type 4 granulomatous hypersensitivity reaction. Here, the antigen or the offending agent is poorly digestible by the macrophage. The macrophage engulfs the antigen and tries to digest it, but the antigen in question here is poorly digestible, and so the macrophage fails to digest it. Instead, the macrophage itself undergoes morphologic change and transforms itself into epithelioid cell. That's why I said earlier, epithelioid cell is nothing but modified macrophage. The macrophage, which is unable to digest the said antigen, modifies itself to form epithelioid cell. Here you can compare this with the antivirus softwares in computers. The geeks in technology here might have an idea about how the antivirus software in a computer works. Is the antivirus software, on detecting a virus or a malicious program, first tries to delete it or remove it. But when that is not possible, what it does is it moves the virus to a vault, which is a secured space within the environment of the antivirus software. Yes, the same way our macrophage here tries to digest the antigen, but when it is not possible, it transforms itself into a epithelioid cell and becomes a permanent vault for this antigen. It also presents this antigen to T lymphocytes. These lymphocytes get activated and produce substances called lymphokines. The various cytokines so formed include interleukin 1, 2, interferon, tumor necrosis factor alpha, etc. And thus a granuloma is formed having macrophage modified as epithelioid cell in the center, surrounded peripherally by lymphocytes. The T cells we discussed now, okay, surrounded peripherally by lymphocytes and healing by fibroblasts. So the story here is the offending antigen is poorly digestible by macrophage. The macrophage tries to digest the antigen, but finding it indigestible, it transforms itself into epithelioid cell and then presents the antigen to the T lymphocyte, which produces lymphokines. The end result is formation of a granuloma which has modified macrophage, that is epithelioid cell in the center, surrounded peripherally by lymphocytes, and healing process happen. Now coming to the individual components of granuloma, which needs further elaboration. The first thing we will talk about is epithelioid cells. The epithelioid cells, as we saw, are modified macrophages, but they are called epithelioid cells because of their epithelial cell-like appearance. They resemble epithelial cells. They are elongated cells having a slipper-shaped nucleus. These epithelioid cells appear as elongated cells having a slipper-shaped nucleus. Another type of cell seen in a granuloma is giant cell, otherwise called multinucleate giant cell. These multinucleate giant cells are formed by fusion of adjacent epithelioid cells. That is how they get multiple nuclei, because they are fusion products of multiple cells. Depending upon the arrangement of these multiple nuclei, there are a few types. When the nuclei are arranged around the periphery in a horseshoe-like pattern, they are called Langerhans giant cells. And the giant cells with nuclei clustered at the center are referred to as foreign body giant cells. So these modified macrophages called epithelioid cells and fusion product of multiple epithelioid cells, that is multinucleate giant cells. These are the two distinct components of granuloma. Here, this is a sketch of a typical granuloma. The one depicted here is a tuberculous granuloma, and what you see here at the center is the central area of necrosis surrounded by modified macrophages called epithelioid cells, which are, as I discussed, elongated with a slipper shaped nucleus. Okay, so this central area of necrosis is surrounded by epithelioid cells, which you can see here, with occasional giant cells or multinucleate giant cells. This is a photomicrograph of a granuloma. Here again, you can see a central area of necrosis surrounded by epitheloid cells here and occasional giant cells. And coming to examples of granulomatous inflammation, there are immune granulomas and non-immune granulomas. The classic example of immune granulomas include tuberculosis, syphilis, and sarcoidosis. Non-immune granulomas are the ones developing from agents like foreign body, silica, asbestos, etc. Immune granulomas like tuberculosis and syphilis needs further elaboration, but we will catch up with them at some other time. For the time being, we will wind up this topic. As usual, I have provided PDF notes in the description. Keep the channel subscribed for more videos, and until we meet in another video, thanks for watching. Bye.